Hello students, welcome to DBMCI MDS. I'm your faculty for Public Health Dentistry, Dr. Shilpa M. So today we'll discuss the public health dentistry questions which were asked in the recent November 2023 INI-CET examinations. So we had a good quantity of questions, around 30 questions, all of which we have discussed in our previous sessions. So we'll see topic-wise, sequence-wise, each of these questions in detail. Okay. So the first question is, swine flu, which was in news recently, is what type of infection in the society? So is it an endemic? Is it a pandemic? Is it an epidemic or a seasonal variation? So endemic is the occurrence of a disease in the usual frequency in an area, whereas pandemic is the occurrence of disease across geographical locations or country to country. So example of pandemic we saw recently, COVID-19, influenza. Endemic examples are endemic fluorosis or goiter in the sub-Himalayan region. So these are endemics. Whereas epidemic, an outbreak of cholera or an outbreak of malaria or an outbreak of dengue. So occurrence of a disease in excess of normal expectancy, that is epidemic. So coming to seasonal variations, what are seasonal variations? So maybe in winter, there are more of respiratory tract infections. We saw in summer, we can have more of GI infections. So these are all the examples. So influenza H1N1 type A influenza or swine flu was declared as a pandemic by WHO in 2009. So the answer is pandemic. So again, we'll see endemic is a constant presence of a disease or infectious agent in a defined geographic area. Epidemic is the occurrence of number of cases of a disease clearly in excess of normal expectancy. That is epidemic. So if you see in a curve, the endemic curve never touches the x-axis because it is always there in a normal frequency, whereas epidemic is a rise and fall curve. So endemic is the usual or expected frequency of disease. Now coming to pandemic, that is over a large geographic area, such as part of a nation, continent, or world, country to country spread. Coming to our next question. A disease occurs in very less frequency in a population in a specific period. So the cases are very less and not related to each other by time and place. So this kind of scattered cases where the disease is occurring in a very less frequency, not related, the cases are not at all related to each other by time and place. What is it called? Is it a holoendemic or a mesoendemic? So the word endemic, or is it sporadic? So the answer is sporadic because the cases here are scattered about. So they are widely spaced in time and space and no connection with each other. Whereas holoendemic means the disease has a high level of infection beginning early in life and affects most of the children population. Whereas a mesoendemic is endemic with a moderate rate of infection. So the sporadic cases which occur very less in frequency are called is the answer for this question. Coming to a question on health indicators, DALY. DALY is, so you can see here the first choice had years of healthy life lost minus years lost due to disability, whereas the other choice is year of healthy life lost plus years lost due to disability. And the other third choice is life expectancy at birth minus life lived without disability. So one thing we need to know is disability adjusted life year or DALY is a health indicator which measures the burden of disease. So here the burden of disease is measured with the choice where you say healthy life lost plus years lost due to disability. So overall it gives the burden. So years of healthy life lost plus years lost due to disability. Years of healthy life lost due to premature death plus years lost due to disability. So It is a best measure of burden of disease in a defined population. One DALY is 1 year of healthy life lost. Whereas you have DFLE, that is Sullivan's Index, which is life expectancy minus duration of disability. That is disability-free life expectancy, or DFLE, that is Sullivan's Index, which is life expectancy minus duration of disability. Now we have a question on universal immunization program. So, universal immunization program covers some diseases that can be easily prevented. So there are some vaccines like measles vaccines, DPT vaccines, BCG vaccines. So it does not include the human papilloma virus vaccine. So the vaccines included under the universal immunizations program are BCG, DPD, oral polio vaccine, measles, hepatitis B, tetanus toxoid, Japanese encephalitis, and Haemophilus influenzae B. So this is a question on universal immunization program. So you can see most of it are previously asked questions also. For example, the question on CPITN probe, the image-based question, it has been asked right in the previous INI-CET examination. The probe, CPITN probe, the image has been given, and the only difference in the choice was the markings were incorrectly given, because CPITN probe is also called as WHO probe, right? The Community Periodontal Index for Treatment Needs probe, or the WHO probe. It's also called as the WHO 621 probe, because it was given in the Technical Review Series 621 of WHO. So the markings of CPITN probe are, so other specifications, first let me tell, it has a 0.5 mm ball tip. It is 5 gram in weight. Working forces up to 20 grams. So the markings are, as you can see very clearly in the image, it is a black band from 3.5 mm to 5.5 mm and additional rings at 8.5 mm and 11.5 mm. So the other choices like which gave 3 mm or 5 mm or 11 mm, please don't get confused. The answer is CPITN probe with black band from 3.5 mm to 5.5 mm and additional rings at 8.5 mm and 11.5 mm. So this is the CPITN C probe, or the clinical probe. Whereas the CPITN E probe, or the epidemiological probe, has only the black band from 3.5 mm to 5.5 mm. Coming to the next question, a disease with incidence much higher than prevalence in the community means. So first we need to know what is incidence. Incidence is the number of new cases of a disease in a defined period by the population at risk into 1,000. Whereas prevalence is the number of total old and new cases in a specific period by total population into 100. So you can see incidence is the occurrence of new cases. Prevalence is the old and new cases together, the total cases, the prevalent cases. So when you say incidence is much higher than prevalence, that means the new cases are going on occurring, but the total cases are less than the new cases. That means, of course, the answer is that disease can be either very fatal or easily curable, because if it is non-fatal or non-curable, that means then the total cases will increase and the prevalence will be more. But here the question is incidence is more, that is in a short time span. So as we can see, when there is immigration of healthy people or out-migration of cases, then the prevalence will decrease. Whereas when there is a better reporting of cases or improved diagnostic facility, that time the incidence will decrease and the prevalence will increase. So prevalence is incidence into duration, which is the formula connecting incidence and prevalence. That is, prevalence is incidence into mean duration. Now coming to a question on odds, that is the probability of an event occurring to probability of event not occurring. So the doubt will be between choices A and B. Is it odds or is it odds ratio? Because risk ratio and relative risk are the same. So please remember, the probability of an event occurring to a probability of event not occurring means odds. So it is odds is probability by 1 minus probability. It's a ratio of occurrence to non-occurrence. So it is the odds are the chance of frequency of occurrence of a characteristic relative to its non-occurrence. So we already saw in odds ratio that odds ratio is the odds of the association of of a disease when exposure is there to odds of disease occurring when there is no exposure. So that is odds ratio. Whereas odds is the probability of an event occurring to not occurring. When it is a ratio between odds of a disease occurring in an exposed towards or odds of a disease occurring non-exposed, that time it is an odds ratio. So odds is probability of an event occurring to probability of an event not occurring. It is probability by 1 minus probability of the event not occurring. So it is a ratio of occurrence to non-occurrence. So the next question is odds ratio calculation. So you have a question where the exposure present, disease present is 12. The exposure present, disease absent is 20. Exposure absent, disease present is 8. And exposure absent, disease absent is 30. That is A, B, C, and D. So odds ratio is also called as cross product ratio, which is the strength of association between exposure and disease, which is derived in a case control study. Unlike in a cohort study where you have the direct estimate of strength of association, which you get in a relative risk, this is an estimate of the strength of association, estimate of relative risk, which you get in a case control study. So the formula is AD by BC. So it is also called as cross product ratio. It is an estimate of relative risk, which is derived in a case control study. It gives a strength of association between exposure and disease. So AD by BC is 12 into 30 by 20 into 8. So the answer is 2.25. So if we see which are the estimates of strength of association between exposure and disease in a cohort study, we have relative risk, attributable risk, and population attributable risk. So odds ratio is the odds of the event in one group, for example, those exposed to a drug, divided by the odds in another group not exposed. So odds ratio of 1 means there is no association. Odds ratio less than 1 means it is a risk factor, and odds ratio more than 1 means it is a protective factor. Example, a drug or a therapy. With the same table, with disease present, exposure present, 12 cases, and so on, A, B, C, D, with the same 2x2 table which was given for odds ratio calculation, we have the risk difference calculation question, which means we have to calculate the attributable risk. As I said, one which we derive from a cohort study. So A, 12, exposure present, disease present. 20B, exposure present, disease absent. 8, that is C, exposure absent, disease present. And 30D, that is exposure absent, disease absent. So what is the formula for attributable risk? So relative risk, the formula is incidence among exposed by incidence among non-exposed. So that is relative risk, I'm telling, the formula is A by A plus B. Disease among exposure where it was there. So it is 12 by 12 plus 20. By incidence among non-exposed, that is 12 by 32 by 8 by 38. This was if relative risk was asked. I will show the detailed explanation for this question, that is attributable risk, which is the difference, risk difference, A by A plus B minus C by C plus D. So according to the choices that were given, when we round off, 0.2 is the most appropriate answer. So incidence of disease among exposed minus incidence of disease among non-exposed. So that is the answer for a question on risk difference. So if it was relative risk, we had to risk ratio, that is, we had to divide it. Here, attributable risk based on the choices given, the most appropriate answer is when we subtract it as a risk difference, we are getting the answer 0.16, which we round off to 0.2. So the strength of association in cohort study, as I told, you have risk difference or attributable risk. The interpretation is so much disease can be attributed to exposure. This much oral cancer can be attributed to the tobacco chewing. And relative risk is so many times the oral cancer risk is higher in chewers compared to non-chewers. Whereas population attributable risk is the incidence in the total population minus incidence among non-exposed. This we tell when we have to tell when we modify the risk factor in a community, how much annual incidence of the disease we can reduce. To give that impact, a public health impact, we use the population attributable risk. So there we saw all the concepts. We saw odds ratio, we saw odds ratio, we saw relative risk, attributable risk, and population attributable risk. So in attributable risk, one more thing is a formula is incidence of disease among exposed minus incidence of disease among non-exposed. That is an attributable risk. So you can divide it again by incidence among exposed. But you see the choices because when they tell risk difference, if you subtract it, you will get the answer. Now we come to a very simple question on data. The question was data in statistical methods is. So is it like an arithmetic unit? Is data like a kg liter? Or is it a sample in a group, or is it a group of samples? So we know data can be qualitative data, quantitative data, any measurement that you record and you denote it as a diagram or a table or a chart, and which you further make it amenable for statistical analysis. So the observations recorded, that is data. So this was exact question. The observations that you record is data. Now, qualitative data you can have as good, fair, poor, or, eye color. This can be qualitative data. Your nominal and ordinal data, the name, hair color. This is qualitative data, whereas quantitative data is which you can number. Height, weight, which you can number. This is quantitative data. Now coming to the question, standard deviation is explained by. So is it the explanation for standard deviation is the choices given here. Is it a measure of average? Is it a measure of central tendency? Is it that? Is it standard deviation? No. Is it the most commonly occurring observation? So most commonly occurring observation is one of the measure of central tendency. What are the measures of central tendency? Mean, median, mode. Most commonly occurring observation is mode. Measure of average, that is, it can be arithmetic mean, or in skewed data, it can be median. So standard deviation is explained by, standard deviation is a measure of dispersion around mean. So when we want to see the dispersion from the mean, we have standard deviation, which is also called as root mean square deviation. So it is a measure of dispersion. So what are the measures of dispersion? We have range, we have mean deviation, we have standard deviation, and coefficient of variation, which are the most commonly which when we speak. In that, the most common is standard deviation, most appropriately used measure of dispersion. Standard deviation is square root of variance. So root means square deviation, standard deviation. So because it is a square root of variance. So variance is the distance of a data from the mean. So square root of variance is standard deviation, or root means square deviation. The formula is square root of sigma x minus x bar whole square by n. So that means it is square root of variance, that is square root of the average of the deviation from the mean. X is the individual data, X bar is the mean. So you have to minus each data from the mean. Then you have to sum it, square it, divide by n and take the square root, where n is the total sample size. And that is total number of observation is n. X is the individual observation, X bar is the mean. So we see the deviation from the mean in this in a square root fashion. It is the most amenable for all our statistical functions. So it is most appropriate and most commonly used measure of dispersion. So again, the question is on standard deviation only. So I will discuss the other choices in this, because the most common measure of variation when measuring prevalence of malocclusion in a community, the answer is standard deviation only. So the other choices given was variance. I discussed variance also. What is range? Range is the simplest measure of dispersion, that is the difference between the highest value minus the lowest value. It is the simplest measure of dispersion. So what is standard error? Standard error is standard deviation by square root of n. It is because when we have sample parameters and population parameters, we have a difference. So that standard error is the difference between the sample and population values. So as I told, range is highest minus lowest value and variance a square of the standard deviation. Now, next question is outliers are not affected by. So is it range, is it mean, or is it standard deviation? So when you have outliers, that is extreme high or low value, for example, in a mean. So if you have a value 2, 2, 2 and 100, of course, the mean is going to be distorted and not true representative of the data set of 2, 2, 2, right? Which is mainly, so you have a data set, for example, 1 to 10 and then 1000. This is another example. So 1000 is the outlier, which is extreme higher or lower value. So in these situations, if you see the measures of central tendency, the disadvantage of mean comes here, where median is most appropriate when you have outliers. Whereas the question here is, among the choices given, which is not affected by outliers? Here we have a measure of dispersion that is not affected by outlier. That is the interquartile range is not affected by outlier. Because suppose if you have a set of observations, you decide, you arrange it in ascending or descending order, and you come to the conclusion which is a median. Arrange the set of observations and you check which is the median. So once you check the median, you have the second quartile or Q2 because it has divided the data set into two parts, right? So now you have two parts. The median has divided the data set into two parts. That is, a Q2 has divided the data set into two parts. Now from each of the two parts, again take the median. That time you get your Q3 and Q1. You minus Q3 to Q1, you get your interquartile range. So this is not at all affected much by outliers. So interquartile range is not affected by outliers. Interquartile range is the difference between the upper Q3 quartile and the lower Q1 quartile. So when you divide the data set into two halves by the median or the Q2, you get two data sets. Again, check the median from both the data sets. That time you get the difference between the Q3 and the Q1. From those two medians, you get the interquartile range. This number will not be affected by the outliers since it uses the middle 50%. It is not affected by outliers or extreme values. So ratio of standard deviation to mean. So it is a very clear-cut question. You have the formula standard deviation by mean into 100 is coefficient of variation, which is a measure of dispersion. For example, when you have two types of data sets, you have a set of data which is a measurement of height of a group of school children, and you have the weight of group of school children. Now, both have their own variability. That is, with mean and standard deviation, both the groups of data set, height has a mean and standard deviation, weight in the same group of children has a mean and standard deviation. But just by seeing that standard deviation, sometimes you can't tell properly how much variability is there within that. But by coefficient of variation, you can tell exactly which data set is more variable. So it is a measure used to compare relative variability. So it is a unit-free measure to compare dispersion of one variable with another, as I gave the example of height of weight in a group of people. So it is standard deviation expressed as a percentage of mean. So the formula is standard deviation by mean into 100. And we have a problem here to solve also. This is also given. Mean is 49. Standard deviation is 8. Calculate the coefficient of variation. So it is 8 by 49 into 100. The formula is very clear cut. So the previous question was ratio of standard deviation to mean. Answer is coefficient of variation. Already I saw the other choices, standard error and range. Coefficient of skewness, you have the skewed data, and the coefficient that you measure for the skewness is called as the coefficient of skewness. We'll come back to coefficient of variation calculation. That is, mean is 49, standard deviation 8. The ratio of standard deviation to mean is coefficient of variation. Calculate coefficient of variation. It is 8 by 49 into 100. So the answer is 16.32. We'll come back to skewed data in the next question. So I'll keep it there. Now we come to when is data set not according to Bell's distribution. So here we'll discuss that. So the choices are when range is 5 times standard deviation, or when range is more than interquartile range. So as you know, in a Bell's distribution, mean, median, mode are equal. That is, in a standard normal distribution, mean, median, mode coincide. So when a data set is not according to Bell's distribution, so if there are no outliers, it is a normal distribution. That is choice C. When we have up to 3 standard deviation, it is a normal distribution. So when mean is much lesser than median, that is when the data set is not according to Bell's distribution. So that time you have, this is a normal curve. So that time you have either the positively skewed where the tail is more towards the right, or you have the negative skewed where the tail is more towards the left. So in a right tail distribution, mean is greater than median greater than mode. That is in a positively skewed distribution, mean is greater than median greater than mode. Whereas in a negatively skewed distribution, mean is less than median less than mode. So mode will always be at the topmost point, students. Please remember. Don't forget that in a positively skewed or negatively skewed, mode is the one which is at the highest, because mode is the most frequently occurring value. So please remember, mode will be on the highest point. In a right tail distribution, mean greater than median greater than mode. So mean will be towards the right side. Whereas in a left tail distribution or a negatively skewed distribution, mean less than median less than mode. So mean will be in the leftmost side. Whereas in a normal curve, mean, median and mode coincide. So there we saw skewness. Now we come to parametric and non-parametric tests. So in a study done to assess the efficacy of a hypoglycemic drug in diabetic patients. So you have one group of patients, diabetic patients. A study was done to assess the efficacy of a drug, hypoglycemic drug on that diabetic patients, and glycosylated hemoglobin values, HbA1c values were checked before and after therapy. It is one set of sample, 2 times the observations were recorded before and after. Statistical test to be applied in the study is. So you have the answer as dependent value or paired t-test. Paired t-test compares a mean of 2 measurements taken from the same sample, whereas chi-square is for categorical variables or to check the statistically significant difference between proportions. Unpaired t-test compares means of 2 samples. For example, you have a group of people using mouthwash and group of people using a standard gold standard mouthwash, for example, chlorhexidine, and a group of people using your herbal mouthwash, which was newly formulated, and you have 100 people in each group, suppose, as an example, and you want to check the difference in the plaque levels between each. That time you do unpaired t-test, that is independent sample t-test. Whereas in this, where you check before and after, whenever you have on a same group of patients, you do a paired t-test, which compares the means of two measurements taken from the same sample. Whereas Pearson correlation coefficient measures the strength and direction of the relationship between two variables. So as height increases, does the weight increase or decrease? So you know the correlation coefficient is R. It ranges from -1 to +1, indicating negative correlation to positive correlation. And in between 0 means no correlation. So that is Pearson's correlation. So the answer for this question is paired t-test. So related question is next, that is, which is a non-parametric equivalent of a paired t-test. So when do you use parametric and non-parametric tests? Parametric tests you do for quantitative data or in a normally distributed data where you have certain assumptions. That is, the data is normally distributed and it is a qualitative data. Whereas non-parametric tests we use when there are no assumptions and the data is skewed or quantitative. For either nominal or ordinal or skewed data, we use non-parametric tests. So we have equivalent of each, for each test in a parametric, we have an equivalent non-parametric. So as I told, for unpaired t-test or independent sample t-test, you have Mann-Whitney test. For ANOVA, which is for 3 or more groups, when you are checking the difference, statistically significant difference between 3 or more groups. For example, the same example which I gave, you have chlorhexidine and mouthwash. Maybe you have one more mouthwash, 3 groups. So that time you have to do an ANOVA to check the difference in plaque levels between each of these 3 groups. So the non-parametric equivalent of that is Kruskal-Wallis test. So here, for a paired t-test, the non-parametric equivalent is Wilcoxon-Signed-Rank test. So Wilcoxon-Signed-Rank test is the non-parametric equivalent for a paired t-test. Kruskal-Wallis test is the non-parametric equivalent for ANOVA. And for a two-way ANOVA, where there are more than 2 independent variables or more than 1 independent variable. For whereas in ANOVA, one-way ANOVA, we have only 1 independent variable. Independent variable is the cause and the dependent variable is the outcome. Independent variable can be manipulated. Dependent variable cannot be. So the cannot be manipulated. So the non-parametric equivalents for each of these tests, starting from, you have the independent sample t-test, that is a two-way ANOVA. It is Mann-Whitney test. For paired sample t-test or dependent sample t-test, you have Wilcoxon-Signed-Rank test. For one-way ANOVA, you have Kruskal-Wallis test. And for two-way ANOVA, you have Friedman test. Now we come to the question, application of group study to individual is. So you have ecological studies, which is part of your classification of study designs. You have observational study and experimental study. Under observational study, you have descriptive study and analytical study. So under analytical, you have case control, cohort, cross-sectional and ecological study. Ecological study is done when you do it on a population. Most of the time, we take the data which is already there and we generate the study results based on the aim of the study. So when you have, for example, a study result on a group of population that this much sugar consumption is there per capita in this group of people. Based on that ecological study, for each individual in that ecological study, you can't tell. For example, a person is consuming 10 teaspoons of sugar per day was the outcome of an ecological study, which was told as an average of that study. But doesn't mean individually, each person is actually consuming so much. So that is ecological fallacy. That is the logical error that occurs when the characteristic of a group are attributed to an individual. So application of a group study to an individual is called as ecological fallacy. They assume what is true for a population is true for individual members of that population. So example, per capita sugar consumption measured at group level, if it is told that it is same for each individual, because for each individual it may vary. That is ecological fallacy. Now we come to the question from healthcare delivery system. According to the WHO primary healthcare concept, Government of India has provided primary health center. For hilly areas, you have at what proportion? What is a question that is asked? Because even for the plains, there is a certain proportion. You have sub-centers, you have primary health centers, you have community health centers. Here the question is, for hilly areas, how much population is covered by one PHC? So in hilly areas, one PHC covers 20,000 population. In plains, one PHC covers 30% population. Sub-center, in hilly areas, sub-center covers 3,000 versus 5,000 population for general or plain areas. Community health center in hilly areas, it covers 80,000 population to, in plains, it covers 1,20,000 population. World No Tobacco Day is celebrated on. So this is a very clear question. December 1st is World AIDS Day. April 7th is World Health Day. May 31st is World No Tobacco Day. Coming to the next question. The best way to take care of oral hygiene in critically ill patients to prevent ventilator-associated pneumonia. So you have a critically ill patient where actually your mechanical plug control, be it power toothbrush or mechanical toothbrush, won't be very appropriate. So mouth rinse, according to the protocol, mouth rinse or using chlorhexidine or aspiration to remove the salivary secretions from becoming pneumonia. This is the main goal here. You have a critically ill patient. You want to prevent the aspiration of saliva and you want to maintain oral hygiene. So oral hygiene of choice here is cleaning the area, maybe with the cotton or a tweezer or a gauze, and also using of mouth rinse like chlorhexidine or betadine. Space maintainer is under which level of prevention? So you have levels of prevention question here. So space maintainer is used as a method of prevention of malocclusion. So the choices are health promotion and specific protection, both of which come under primary prevention. Secondary prevention, you have early diagnosis and prompt treatment, which is the intervention. And the other choices, disability limitation and rehabilitation is the intervention for tertiary prevention. So tertiary prevention is done, prevention at the advanced stage of the disease. Whereas space maintenance is done at the before the initiation of the malocclusion. So it is a primary preventive measure and it is a, you are giving the modality as an intervention. So it is specific protection. So primordial prevention is prevention of emergence of risk factors itself. So right from your prenatal counseling to mass education, you have high-risk programs which are integrated to community-based programs. This is primordial prevention. Primary prevention is action taken prior to onset of disease. For example, here prior to onset of malocclusion, which removes the possibility that that disease will occur. So that is the answer for this question. Then you have secondary prevention, which halts the progress of the disease at its incipient stage and prevents complications. And tertiary prevention is done at the advanced stage of the disease, where you have the disability limitation and rehabilitation. For example, in a case of prevention of dental caries, you have health education modalities and you have topical fluoride application under primary prevention. Topical fluoride is under specific protection. Also, it could be Pitt and Fisher sealants. Under secondary prevention for oral cancer, you have screening. And for anywhere where tertiary prevention comes under rehabilitation, you have prosthodontic rehabilitation. Under disability limitation, for prevention of periodontal disease, halting further periodontal disease, you can do periodontal therapy. or it could be extractions, or it could be endodontic evaluation or pulp therapy for when it comes to secondary level of prevention for caries, so on and so forth. Highest level of community participation is in a community is when it is according to. So here we want to know which is in community participation setup, which is the highest level of involvement of the community. So already we have seen what are the principles of primary healthcare: equitable distribution, community participation, intersectoral coordination, and focus on prevention. So in community participation, it could be just the use of the services only, which is very passive participation by the community, or it could be contribution of resources by the community. It could be according to the felt needs of the community. But here the question is highest level of participation. Highest level of participation is when it is by the community, which we have all these questions, students, in some way or the other, we have already discussed. So here it is by the people. So where the people are involved and where people are highly empowered. So that is planning of intervention by the community itself. That is the highest level of participation, where they are empowered to make decisions. So community participation is a major principle of people-centered health systems. For example, in a primary healthcare setup, it's health by the people. Now we come to, so the 4 pillars of primary healthcare. It could be principles, or the question can be 4 pillars of primary healthcare. That is equitable distribution, community participation, intersectoral coordination, and appropriate technology. Now we come to a question on social sciences or behavioral sciences. In population health, culture is described as, so culture is a learned behavior. Is it dynamic? Because then again, there are some choices which shows beliefs that guide behavior, but static. Beliefs and norms, but static, not conducive to health. No. Culture is, of course, it is passed on from generation, so it is dynamic and it is a learned and shared behavior. So culture is a learned behavior which is socially acquired. So choice A is the right answer. The most scientifically proven cost-effective public health measure to reduce occlusal dental caries in children. So scientifically proven, cost-effective. So of course it is before the disease burden starts, mostly in the model of primary prevention. So here we have primary prevention methods like you have health education, first of all. Then you have pit and fissure sealants. Of course, ART is once the disease occurs. Here it is cost-effective measure to reduce occlusal dental caries. So that is in the occlusal caries, when you have deep pits and fissures, where the food debris and bacteria gets trapped, where you have to make the tooth self-cleansing and make the deep pits and fissures in the occlusal area self-cleansing and prevent the trappage of food and debris and bacteria. Also, efficient cleaning can occur. That is the delivery of pit and fissure sealants, which is the most scientifically proven cost-effective public health measure to reduce occlusal dental caries in children. Now, a question on palliative care. Due to increased life expectancy, there is rise in chronic disease, cancer, dementia, and degenerative disorders, which makes the need for palliative care very essential. So what is the palliative care? Palliative care improves quality of life of patients. It is in an end stage when you can just improve their quality of life. So you are helping the patient as well as their families with life-threatening illnesses to reduce their suffering, and where their physical, psychological, social, and spiritual parameters also can be improved. So the main word here is quality of life. So there were choices given and it was asked which is the best choice. So please put the other choices if you know in the comment section. But the choices: disease is main concern, patient is supreme, goal is to improve quality of life. Because the intent to cure in an advanced stage of disease, it can't be very appropriate. Death is neither to be hastened nor postponed, and don't just do something are not appropriate choices. So the quality of life is the goal. Patient is supreme, patient-centric. Disease is main concern. The disease is main concern because all the symptoms and the complications related to that disease and the suffering, you are looking to alleviate that and control that in palliative care. So palliative care improves the quality of life of patients and that of their families. Now we have a question on match the following from the oral epidemiology of oral cancer chapter, that is tobacco cessation section. You have the pre-contemplation, contemplation, maintenance, and action given on the left-hand side, and you have choices given on the right-hand side. So which were the most appropriate choices were the question. So if you know the choices, please put in the comments below. The most appropriate choice, as I know, is like this, because here, if you see carefully, knowing the ill effects of tobacco and smoking, thinking of quitting. Because pre-contemplation, here, obesity runs in my family and I can't do anything about it is totally before thinking anything. That is pre-contemplation. Knowing the ill effects and thinking of quitting is contemplation. Knowing the benefits of physical activity, now walking for 30 minutes 5 times a week. So now it is happening. That is action. Mr. Pankaj quit smoking 1 year back. Now not smoking since 1 year or not chewing. That is maintenance. So as you know here, maintenance is a right choice where the match the following has occurred properly. So if you can look into detail the trans-theoretical model or the stages of change model given by Prochaska and De Clement, you have pre-contemplation where the patient is not acknowledging there is a problem. In the choices given below, obesity runs in my family and I can't do anything about it. That is pre-contemplation. Not acknowledging there is a problem and that the behavior has to be changed. To contemplation. So now there is a problem. I know tobacco smoking is harmful. Tobacco chewing or smoking is harmful. So acknowledging there is a problem, but lacks certain confidence. That is contemplation. Then you have preparation. You are getting ready to change. You have decided on this date I will quit. That is preparation. Action is when the behavior has been changed and the healthy promoting lifestyle has been adopted. That is action. Walking, because physical activity is beneficial, I am walking 5 times a day, 30 minutes a day, 5 times a week. That is action. And maintenance is when the healthy behavior is in place since a certain time period, not smoking since 1 year. So that is maintenance. So this is a trans-theoretical model or stages of change model, mostly used in tobacco cessation. So in tobacco cessation, you have your 5 A's: ask, advise, assess, assist, arrange, right? So this is also coming under tobacco cessation counseling, which is tobacco cessation counseling comes under primary level of prevention. A group of physicians had to assess 100 chest x-rays as normal and abnormal. So you have physicians who have to be calibrated. So each physician will give the judgment. So it could be assessing x-rays or it could be assessing caries is present or not also in our scenario. So how you are calibrating based on intra-examiner, that is within examiner, and inter-examiner, that is between examiner calibration. The statistic which gives the value is kappa statistic. So kappa statistic here is 0.71. 1, if you get, it is perfect or excellent. Above 0.8, it is good. So here it is 0.7. So it is intermediate. So kappa statistic is used to calculate intra and inter-examiner reproducibility. It is an index which compares agreement against that which might be expected by chance. So you have to, for example, in a caries, in survey chapter, it is given when it comes to kappa statistic. The clinicians or the investigators should discuss all the rules carefully. The instruments should be also calibrated properly so that they examine the correct way. Then the calibration, intra and inter-examiner calibration is done. Same examiner on 2 intervals and between the examiners. So kappa statistic 1 is total agreement, or you can call it as excellent also, because sometimes the choices may give slightly different words, but you know, total, excellent, perfect agreement. That is 1. Greater than 0.8 is good. Of course, poor is very less. You have 0.4 to 0.6 moderate, 0.6 to 0.8 substantial. So here we can go for 0.71 as intermediate agreement. Now again, it is related to validity. It can come, you have seen validity, reliability in index because you are measuring the disease status. You could see it in survey also. Validity is the accuracy and precision is the reliability. So here you have a test which has to be measured against a already validated test. So what kind of validity will measure the validity of a new test against an already validated test? So when you have a set of questions in a questionnaire and your aim is to assess the knowledge of a group of mothers regarding early childhood caries. So if you check whether each of this question is according to the aim of your questionnaire, what you want to check, that time you do a content validity. Whereas when you want to check the theoretical concepts, in that you do a construct validity. Content validity is a test fully representative of what it aims to measure, which is judged by the researcher. Construct validity. Does the test measure the concept that it is intended to measure? That is construct validity. Criterion validity measures the outcome designed to measure. So the answer here is convergent validity. You are measuring the test against an already validated test. Refers how closely a test is related to other tests that measure similar constructs. So there we have discussed all the questions that were asked in the yesterday's INI-CET examination, and we have discussed all of these concepts in our previous formats, previous sessions. Maybe the wordings were little here and there. So please note down these questions and answers and the choices for your further reading. All the best for your further examinations. Thank you.